critical mass, so let's go ahead and get started. Michelle, can you hit record, please? All right. Good morning, everyone. Sarah Bartleman with the Oregon Health Authority. Welcome to our second cost growth target tag meeting. I thought we would start with quick introductions. We're still gelling as a group, and I think we have some new names and faces participating today. So for the sake of coordination, I've been grabbing a bunch of your names as you've logged in. So why don't I run down the list, call you out, and you can just introduce yourself, name an organization, and then we'll see if there's anyone else that I've missed. So in no particular order, Jim.
Yeah, hi, Jim Gardner, Advanced Healthcare, Chief Operating Officer. How you doing?
Welcome, Jim. Cable. Gail.
Morning, this is Gail Woods. I'm with the Department of Consumer and Business Services, and I'm a senior policy advisor there.
Welcome. Kristen.
Good morning, Kristen Downey, Director of Government Affairs for Providence and Oregon.
Annalisa.
Good morning, I'm Annalisa Gellerman from Washington State. I'm the manager of the Healthcare Cost Transparency Board, which is our similar effort up north. We're about a year behind you. Glad to be here, Sarah. Thank you.
David.
Hi, I'm a retired health economist, and I'm really interested in efforts to contain and control the costs of healthcare.
Richard.
Richard Gibson, physician informaticist at Comagine Health.
Vince.
Hi, Vince Porter with Cambia Health Solutions. I'm supporting Jared Collings, who sits on it for us.
Susanna. Michael Fields. Morgan Belts.
Hi, Morgan Belts, Government Affairs Associate at Oregon Business and Industry.
Andrew.
Good morning, Andrew Tarab at Providence Health Plans, and I lead the Vice President of Analytics and Informatics.
Dave. Anna Morales.
Hi, this is Anna Morales. I'm with United Healthcare. I'm the APM Program Director.
Jeremiah.
My name is Jeremiah Brickhouse. I'm the Chief Information Officer of the St. Charles Health System.
Chris.
Morning, everyone. Chris Hogan, CFO at Advanced Health.
Anna Sue Rincon. Michael. Jeff Winkley.
Good morning. Hi, this is Jeff Winkley. I'm the Director of Hospital Financial Programs from the Oregon Association of Hospitals and Health Systems / Apprise Health Insights.
Welcome. Tracy. John. Bijal. Bud.
Hi, this is Bud Volz from United Health Group.
Jared.
Hey everyone, this is Jared Collings from Cambia Health Solutions. Happy to be here.
Mark.
Hey, Mark Florian with Pacific Source.
And Jermaine. All right. Did I miss anybody? Staff not included.
Hi, this is Peter Hendel. I'm a business analyst with United Health Group.
Welcome, Peter.
And yeah, this is Bijal Hauser. I'm with United as well.
Great, welcome. All right, and on the staff and consultant side, on the OHA team, we have Trang, Ishan, Stephen, Zachary, Ben, and we have our consultant with Baylor Health, Megan Burns, on the line with us too. Did I miss anybody on the staff side?
Hi, my name is Tracy Cole. I'm with CVS Health. Apparently I was on mute before when I was speaking.
Great, welcome, Tracy.
Thanks.
All right, let's go ahead and get started. So quick housekeeping, we are recording the meeting. The recording will be posted on our TAG webpage later. All of the materials for today are also up on the TAG webpage. We had a technical glitch where the materials were posted in the wrong place. That got corrected this morning. Sorry about that if anyone went looking for them, but they are there now. And as before, our chat function for this call is turned off. If you have any logistic questions, you can ping staff in the chat, but no cross tag participation in the chat. We'll keep that all voice today. So let's go ahead and jump in. The first thing on our agenda is to just review the February meeting summary. As we are more of an ad hoc group, we're not going to necessarily formally approve the minutes, but I did want to recognize that I may not have captured everyone's name and organization that was participating or everyone that was participating. So if there's any errors in the attendance, please let me know. And then we didn't really make any decisions last meeting. We mostly introduced the cost growth target work. We had a number of initial technical questions that we started to talk about. Then we jumped into the charter and work plan for the technical group, and then started talking about the data submission template itself. And we had some pretty detailed questions. We got a lot further in the weeds than I anticipated for our first meeting, and I think we will continue that in today's meeting. So I don't want to go too far in the details because I know we're going to pick up the technical conversation very shortly, but are there any questions or comments about the February meeting summary? Okay, hearing nothing. Again, if I did get any of your names or organizations wrong, please let me know. I apologize in advance for that. Our first heavy agenda item for today is the data submission template and guidance document. So this is part 2 of the conversation, but in a lot of ways it's also the first time we're talking about this because this is the first time we've shared the full guidance document. Specification manual, implementation manual. We'll probably use all of those terms interchangeably. We haven't quite landed on that. So we did talk about an early draft of the template last month. Today, we're going to talk about the revised draft and some introduction to the guidance document itself. Michelle, next slide, please. I just wanted to provide a little bit of a refresher about the purpose of this document, both of these documents. So the data submission template is the file format that payers will use to submit the annual cost growth target data, and the specifications document are the instructions. So that is sort of our living document at this point of all of the details of how to operationalize the file. So it includes some components of the data dictionary. It will include data submission instructions, timeline, where to send it. It will include details about the validation process as we get into that. It will include example scenarios. We had some questions about will it include codes, taxonomy codes, various procedure codes for identifying things, yes, it will include that as well. So as you can see from the draft that we sent out this week, we have started to create that document. There are definitely some gaps. There are definitely some questions that we have for you today. This is very much a draft, an in-progress document, and we expect it will have some heavy edits after our discussion today. Also, as a reminder, we are focused on the initial data submission, which will be calendar years 2018, 19, and 20. We are aiming to do that data submission later this summer, early fall. And then we will revise the data submission template and specifications based on that experience if needed. And then we'll have that as an annual update for the 2021 data submission, which will be submitted in 2022. And final reminder, only payers are submitting data. There is no requirement for provider organizations to submit data as part of this. So provider organizations that are participating, we welcome your feedback and your perspective on this process, but there is not a requirement for you. The data is all coming from the payers. Any questions about the concept before we start talking about the specifics? Okay. Sorry, not yet, Meg, not yet, Michelle, one more. I wanna provide just a little bit of an update on some of the changes we made to the data specification template itself since the last meeting. You asked some really good questions. You helped us identify some areas where we were maybe labeling things in a confusing way, and I wanted to just highlight some of the changes we've made. Michelle, do you wanna pull up the Excel file? We'll screen share a couple of things. I don't want to go again through every single field and column in detail, but I did want to mention a couple of things before we get to the specific questions for today's discussion. So the first thing to flag is that we've changed the number of tabs, the number of buckets for this report to provide some better clarification, some better separation between what we're asking for. So we had a lot of conversation last month about data for members that have been attributed to provider organizations, and then cost growth for members who have not been attributed. So we've broken that out now into two separate tabs. So tab 2 is attributed, tab 3 is unattributed. Again, more detail we can get into, but just high level changes about that. We've also added tab 6, which will be for supplemental information. So currently that tab is blank, but as we were going through putting together the draft guidance document, there were a number of places where we will need more information. So for example, which risk adjustment method or software was used for risk adjustment? What was the patient attribution methodology used? And so we needed a space to collect some of that. And we thought that just building a separate tab into the workbook made more sense than requiring a bunch of separate file submissions as supporting materials. Okay, do those high level changes make sense? Are there any questions or feedback about that? You're all really quiet today and it's making me nervous.
This is Drew from Providence. I admit I've not yet had a chance to review the changes, so I think I need some more time to absorb the revisions.
Fair enough. Let's go then to the let's go then back to the questions in the slides, because I think some of them don't need a detailed look at the template, and I want some feedback before we talk specifically about changes that you may or may not have had time to absorb, which is totally fair, just because I cannot assume that you've all been staring at this since you got it like I have. So the first question is actually not about the template. It is a question that came from the implementation committee. And as we were drafting the template and guidance, we realized we hadn't talked about it yet and hadn't made a plan to talk about it with the tag. So I wanted to bring it today. Michelle, next slide, please. And so that is this question of, oh, nope, sorry, back one, out-of-state residents. So for the data submission, it's clear that we are including all Oregon residents. But the implementation committee had a conversation last year about some of the cross-state scenarios that might come up. So we had the question of Oregon residents who receive care from out-of-state providers, and we had the question of out-of-state residents who receive care from Oregon providers. The implementation committee recommended that we should include out-of-state residents who are receiving care from Oregon providers if that data is reportable and consistent and replicable. And it was kicked to us as a future technical group to talk about whether or not we thought that data was reportable, consistent, and replicable, and if it makes sense to include out-of-state residents who receive care from Oregon providers. So Megan, can I put you on the spot to talk about how the in-state, out-of-state split worked in other states? Sorry, I did not cue you for that at all.
That's okay. That's what I'm here to do for you, Sarah. So in the other states that have operationalized a benchmark or a target program, specifically Massachusetts, Connecticut, Massachusetts, Delaware, Rhode Island, and in the future Connecticut, they have limited the analysis to residents who receive care regardless of where the care has been provided. And so the insurers are reporting data essentially at the member level, and the unit of analysis to identify those members could be their zip code or state, obviously, of residence. I think the question here that the implementation committee was leaving to this group is recognizing that Portland area and in other border towns, consider Portland a border town, there are individuals who might be coming into the state either to seek specialized care or for other reasons, and who are contributing to the overall experience at the provider level or at the payer level. And so the question is there a way to be able to capture that information consistently? For example, looking at the residents and non-residents at a particular provider or health system. Is that something that you could report consistently across insurers, and to be able to do it the same way year after year?
Thanks, Megan. So I think, go ahead.
This is Drew again from Providence Health Plans. I think my reaction to this ask is that I think it inadvertently creates a partial view or a partial understanding of experience, because let's take members who might live, or individuals who live in Southwest Washington who come across the river for care in Portland. You're not capturing all of the other use of that member that is occurring back in Southwest Washington. I could appreciate better the holistic member view of capturing a member's experience when they may cross borders into Southwest Washington. Oregon life moves into Southwest Washington for care, is a more holistic view, and perhaps is less likely to create a distortion about total cost of care. In other words, I don't know if you can really understand total cost of care if you're capturing an individual who lives in Southwest Washington and occasionally comes into Portland for care.
So this is Jared Collings from Cambia. I had similar questions on this. I think there's two questions really, right? The Oregon residents that receive most of their care in Oregon, but may receive some care out of state. It makes sense to pull in that out of state care, as oftentimes it's emergency care or whatever. So that piece makes sense. The piece of out of state members who receive care occasionally in Oregon, to me, it's hard to draw the line. What does it mean? Did they have at least one claim in Oregon? Did they have some proportion of their claims? And it starts to get really complex when you talk about where do you draw the line, and how far away from Oregon does it make sense to go? And so I'd recommend to keep it more straightforward, especially as it's kicking off, and just limit to in-state residents.
Thanks, Drew. Thanks, Jared. Other payer comments? David, do you have your hand raised?
I do. It's my impression, I attended all the task force meetings, and I think for this, the overarching goals, you're not gonna achieve, a perfect reading. It's that there's some consistency between plans, so they're gonna do things differently, but it's based on, for the large enough, the significant bodies of patients and claims, that there will be improvement over time. So I think, getting too fine on where the lines are, especially at this point, might be overkill.
Thanks, David. Other comments, reactions, especially from payers? Are you mostly in agreement with the comments so far that it does not make sense to try to include out-of-state residents receiving care from Oregon providers, given the complexity?
Hi, this is Anna Morales from United. I think also it complicates the way that we would be pulling the data. So if you wanted a population of your Oregon members, that's one certain type of pull. And then now you're asking us to pull in the providers in Oregon so that we could capture all out of state. And so that'd be like two separate pulls.
Thanks for that, Anna.
Yeah, just something to consider.
Other comments, reactions? It does not sound like anyone would be disappointed if we took this off the table, at least for the first data submission, maybe revisit it in a year or two.
This is Tracy Cole from CVS Health. We would agree with that. The focus on Oregon residents at this point.
Okay. Final comments. Feels like we're at a decision. Okay. I guess addendum question. Thoughts about revisiting this in a couple years after we've got the initial data submission figured out?
Sarah, I think I'd like, if we're going to revisit, I think we should, I'd like to hold the OHA responsible to say why. Why do you need to, what's the value of adding that, the population who doesn't live in Oregon, and understanding their slice of experience that happens in Oregon? Because you're not asked the inverse question. And anyway, I mean, so if we revisit it, I think there needs to be justification for why we revisit it.
Okay, helpful. All right, let's go to the next question. On the next slide. So the next question is about the inclusion of student health plans. So this is a very small subset of the commercial market. And as a broad perspective, we want to include all commercial plans that are offering a medical benefit. And so student health plans would qualify. I had originally taken them off the list because we do not include student health plans in our all pay all claims data submission. They are not required submitters. But then Megan asked me why we were doing that. Student health plans are included in cost growth targets in other states because, again, it is a medical plan, it is a medical benefit, and it is part of the commercial market. So why would we be excluding them? So we looked at the DCBS enrollment data for December 2020. Student plans are less than 1% of the commercial market. And it looks like we have 2 commercial payers that have student lines of business, and both of those payers would already be submitting the cost growth target data for their other lines of business. So we're really not talking about any sort of carve out or unique situation for the inclusion of student plans, but we wanted to bring that to you for discussion, pros and cons for including or arguments for excluding.
Sarah, this is Jared from Cambia. I don't know that I have an answer for this. I'd probably have to go see what it would take and ask some internal questions. I'm not actually even sure if it applies to us. I'd have to definitely do some research there.
According to the DCBS data, it does not. I can tell you who the 2 plans are if everyone is comfortable with that. I mean, they're publicly named, so I guess I can just share that. Yeah. It is Aetna and Pacific Source.
This is Mark Florian with Pacific Source. To me, it makes sense that they be included.
Okay. And Mark, from your perspective, this is something that you would easily be able to pull as part of the medical benefit and creating the data file. It's not totally carved out internally.
Correct. I mean, they're essentially like individual plans. So I don't see any special process for including them. Feels like they should be part of it.
Okay, very helpful. I don't think we have anybody from Aetna on today, do we?
Yes, Tracy.
Oh, Tracy, sorry. Sorry.
We do include them currently for Massachusetts and Delaware. I can't speak to the Rhode Island or Connecticut right now, but.
Okay, so at least from Mark and Tracy's perspective, this is doable and there's no real reason to exclude. Any other comments and concerns?
Yes, Sarah, this is Jeremiah Brickhouse from St. Charles. I guess I don't fully understand what a student plan is. So my kids go to Oregon State. So is this the coverage that they get through the university or through a payer?
This is the coverage through a payer that might be offered in conjunction with a university. It's not university, well, sorry, I should let Mark and Tracy and others who actually offer these plans answer that.
This is Mark. I can certainly try. It's kind of an interesting hybrid of a large employer plan and an individual policy. So it's a collection of individual policies offered through a particular university. So again, the benefits are standard. They're required to follow medal levels similar to individuals. So again, I don't see any special challenges with including that in the data relative to other lines of business.
Okay, great, thanks, that helps. So I guess my thoughts is I would include it.
It will be called, the student plans themselves would be noted as unique lines of business. Is that accurate? I mean, their experience is materially lower than your regular employer sponsored coverage or even the individual ACA market, because I mean, this is a student population who's got time to go get healthcare. Anyway, my experience in administering student plans is that it is a lot lower use and cost experience compared to a commercial plan. So I'm hoping that you would at least be able to identify and carve out as needed.
I think the intent would be to identify them separately. Megan, how is this handled in the other states?
So the other states are collecting aggregate data from the health plans, and student plans are incorporated into the commercial market, either as sort of what we've called the full claims, which means that the payer would have the entire experience, or the partial claims where potentially something is carved out and they have to estimate it. So it's not separately identifiable.
I thought that in the draft data submission template, we had a potential line that we had as a placeholder for student health plans, but maybe that was just on the enrollment tab and not necessarily the aggregate cost tab.
Yeah, so you need the separate enrollment in order to calculate the net cost of private health insurance, which needs to be calculated on a market segment by market segment basis. And so for the plans that offer student plans, their experience with premiums and claims would be incorporated into NCPHI, the net cost of private health insurance, that is, whereas the payers that don't offer that obviously wouldn't have that experience. Some of this is just artifacts of how the National Association of Insurance Commissioner collects data in their financial forms.
So it's not necessarily carved out in the data submission other than for enrollment, but to Drew's point about the experience being different and utilization being different, this is potentially something that could be done in analysis, either with the payer or in coordination later to understand the potential impacts that the student or experience of the student health plan enrolled population compared to others, but not necessarily something that we'd be intending to break out officially in the template.
Yeah, I mean, I think that's right, Sarah. I mean, I think that the thing to remember is that this is a very, very tiny slice of the commercial market. And so I am going to go out on a line and venture to guess that you're going to have higher priority analyses that you'll want to do once you are able to analyze what is going on with the cost growth.
Thanks. Other comments or questions?
I had a related question. I didn't see in the exclusion or inclusion about short-term medical plans. Are those intended to be included or excluded?
I'm not looking at it right now. Trang or Megan, do you know off the top of your head?
So short-term medical plans, can you describe them briefly? Do they offer a comprehensive medical benefit? Can you give me a scenario so that I can help understand it better?
I'd probably need a little bit more time to research to provide a great answer. I don't personally work on those, but they're less than a full year of coverage. So the intent is to provide coverage between jobs, for example, or something like that.
I think in that case, they would be included because it's the full benefit just in a shorter time frame. Yes?
That would,
it's
yeah,
not the same as a supplemental plan, which we are excluding.
Right. I think the experience is very different, just with some of those other comments, though.
This is Stephen Rand. So just clarify, would this be similar to like COBRA benefit or different?
Different.
Okay. But the intention from the offset is to only cover like a short period of time.
Yeah, and I think it has to be less than a year. Like it can't be ongoing.
So Sarah, that's something you might want to take offline because of the difference in member months versus.
Yep.
So something
we will take that offline. I want to look back at the DCBS file to see what we had called out when we were counting up potential volume, patient volume or member volume earlier, and what we did with plans at that point. We'll report back. Go ahead. Was there another question from someone? Then I think decision include student plan, report back on short-term medical plans, more to come. Next slide, please, Michelle. And okay, actually, can you switch to, oh, sorry, okay. Intro, then other document. So we have broken out the claims payments into a number of service categories. So inpatient, outpatient, professional, all that good stuff. But then we have had a lot of internal discussion over the last couple of weeks about how granular we should be in creating categories for the non-claims payments. So in the draft specifications document itself, we identified a couple of different options that we wanted to present to you for consideration. So if you want to pull up the data submission draft guidance document itself, it's a lot of text, so I didn't put it on a slide. So that's why we're switching between things. Let me tell you the exact page number. I'm scrolling frantically. Okay. It is the section that starts on page 23. Yes. Okay. So these would be all of the payments that payers are making to providers outside of claims. And there are lots of different ways to categorize this. So the first option, and this is what's currently in the Excel template, would be to have no granularity and only report the non-claims payments as one lump sum. So there would be no ability to understand where payments were going within that category. It would just be everything rolled up into one column. Option
Sarah?
two. Oh, go ahead, Tracy.
Sorry to interrupt you. We can't see the Excel template.
Yeah, we're not screen sharing it. Sorry.
Okay, sorry.
If you want to pull up the data submission guidance draft, we're looking at page 23 and 24, but we're not going to screen share because it's just a ton of text. We'll talk through it. Okay. The second option is to create a lot of granularity and have a whole set of columns that are in some ways parallel to the claims-based service categories. So there are a couple of ways we could break this out. We've provided some draft options in option 2. We could break out non-claims incentive programs, capitation, risk settlements, care management, recovery, and an other category. Option 3, my cat is joining the meeting. Option 3 is similar, where there would be lots of granular categories, but the grouping is slightly different. And this is what Connecticut is using. So there's a capitated global budget case rate and prospective payment category. There's performance incentive payments, payments to support population health and practice infrastructure, provider salaries, recovery, other, and primary care payments. And then option 4 would be we could create our own Oregon custom version that has the right level of granularity and fields that make sense for how we categorize things. So that's a lot of options. We can talk more specifically about what would be in any of the specific categories, but it feels like the first question is, are we in agreement that, this is a leading question, are we in agreement that one field lump sum all non-claims based payments is not sufficient and we want some level of granularity?
I would agree with that. This is Tracy Cole.
I'm not 100% sure I do agree with it, in that there's a lot of interrelationships between incentive payments, risk-based settlements, even capitation payments, and all that stuff kind of blends in together. I mean, I could appreciate the public interest in perhaps wanting to know like some of that granularity, but really at the end of the day, what matters is what we were ultimately paying providers. And I mean, carriers are going to have all sorts of novel financial arrangements with various provider groups that get to a result of affordability. So I think for me in Providence Health Plan, it actually creates a little bit of an administrative burden to have to parse out some of that granularity.
Drew, can I push on that for a second? Like, I hear what you're saying about the interrelatedness between some of the payment types, but it feels like some of these potential categories are sufficiently different. Are recovery payments more distinct than maybe some of the other payment types?
Well, I actually had a question for you about recovery payments, because often our recovery payments go through as a claim payment. And so you could end up with a negative claim payment, but the template doesn't allow us to have negative claim payment. So I wanted to push on that anyway. Recoveries, and maybe every carrier and provider does it differently, but we more often than not, our recoveries show up as a claims adjustment. But that's true. Like, so recoveries are in fact unique, right? That's a little more close to a transaction process, but like bundled payments often get settled as a settlement process. Like you pay on a fee for service basis and then you settle a bundle payment, and it looks more like a risk incentive. Even sometimes I'm trying to think, capitation might be at least more unique in that it looks like a monthly transaction, but pay for performance incentives get wrapped in with total cost of care incentives. Often there's maybe there's one withhold that covers both pay for performance and efficiency performance, and then that gets all bundled together. So maybe we need to do something that's unique for Oregon then.
Yeah, I'm hearing something that's unique for Oregon. I'm hearing yes to some level of granularity, but maybe not as currently written because of some of this interrelatedness. Do other payers want to weigh in on what this looks like for you and what some of the categories that might make sense for you are?
So this is Jared Collings from Cambia. I'd probably have to go back with our finance team and review this. So I don't have a great response today, but my bias is always towards what are we going to do? What sort of comparisons are going to be made with this? And can we have a simplified approach to start with? I mean, this reporting requirements are already highly complex, and this is one of the most complex pieces of it. So I would have a bias that way.
Thanks, Jared.
This is Chris from Advanced Health. I agree with Andrew and Jared. I'd prefer to keep it simple, keep it bundled.
And Chris, when you're saying bundled, are you advocating for a single column, one field, all non-claims payments together, or are you advocating for maybe 2 or 3 sort of a lesser level of granularity?
I would prefer option 1, but if everyone's in support of granularity, I would support having some large buckets that don't add a lot of administrative burden.
This is Anna from United. I think I'm in agreement. I think option 1 and 2 at the most would be a good start. We do something similar with other states. Colorado, I believe, has adopted the HCP land model. So that is way at the granular level. So we've done that as well. But I think as a first start, option 1 and 2 would be our preference.
Thanks, Anna. Other payers want to weigh in? Other folks want to comment in support of why we would want more granularity? I think we could talk about some of the use cases for this and how it would be used. I did hear those concerns. I think from a state perspective, one of the first considerations we are trying to bring to this is if it's just one category or 1 or 2 very large buckets, there'll be some immediate questions about, well, what happens? And there'll be no ability to understand any of the nuance. And that seems like a limitation in understanding trends and interpreting these analyses going forward. But I definitely hear what you're saying about the complexity of this potential request.
Sarah, can I provide just a little context on to a provider perspective?
Please.
So providers in Rhode Island have been reviewing payer-reported data, and in Rhode Island, it looks more like option 2 than option 3 in terms of the granularity of the non-claims-based payments. And because many of at least the providers in Rhode Island and providers in states where there's a significant amount of value-based payment being used, more and more of their payments are being pushed into the non-claims categories. And so from their perspective, they wanted to be able to justify that their trend increases to the extent they existed. In some cases were sort of positive because they were a result of incentive payments or quality improvement payments. And so I just want to highlight that as an alternate perspective. I fully understand the complexities in reporting the information, but just wanted to provide some of the provider perspective to how they might be feeling about the categorization of these particular payments.
I'd like an opportunity just to be clear with, at least for Providence, many of our risk arrangements bundle in all of those things. And so it becomes like a one number at the end of the year for some of our providers. And so it's not so much a complexity thing as it is the sum of the program can't necessarily be broken into parts. It is a total package. And I think if you ask us to break it into the parts, I don't know how we'd report it.
Okay. Other thoughts on this? This is really helpful.
Yes, and I understand that they're going to be collecting this APAC, and I know the payment.
Oh, Gail, the elephant in the
we
room.
were collecting at a separate.
All right, we are getting some feedback.
So I don't understand why we just don't.
Yep, folks, if you're not on mute, can you? Gail, you are correct. We are collecting a similar types of data in the all payer claims database in the payment arrangement file. And we've got folks on the line who can speak more specifically to that. However, none of that data is as inclusive as the cost growth trend data, and none of it is broken out for the provider level reporting. We did have a long internal conversation about whether or not we could use that APAC file instead, and realized that we just would be missing that whole provider level layer, and it needed to be part of the data submission.
Thank you.
Other thoughts, reactions, questions about this? All right.
Sarah,
go ahead.
So not so much about non-claims payments, but it's more about the template and not allowing negative numbers in any of the claim category columns. And I just wanted to probe a little bit on that, because although it is very unlikely that we wouldn't have a negative number, I think many carriers probably have recoveries go through their claim system. So it is possible to have a negative number if you're looking on an incurred basis. It is, if you look at like a lag triangle or anything, it's possible to have negative numbers on an incurral basis.
And would the
I just wanted to, it's not very unlikely in the sum, but it's possible.
But it's possible. And would the way to fix this would be to just remove that no negative numbers requirement to capture any of the very unlikely but possible scenarios?
That's what I'd recommend.
Okay, can other payers give us some perspective? Do you also have the recovery payments going through claims? Is this, slim possibility, but could happen on your sides as well?
That's true for advanced health.
Same for Cambia. Our recoveries generally go through claims.
Okay, thank you. I don't see an immediate problem. I'm probably missing something in the nuance, but Megan, are there any immediate reasons coming to your mind why this would be a problem? It feels like an easy change to me.
I think it's totally doable. It's just as a helpful control in some cases, but no reason why not.
Okay, we can make that change. I think one of the things that we're also working on building at the same time as we're developing the specifications is what some of the automated edit checks on the file would be. And no negative numbers seems like an easy one for certain fields, but in this case, maybe not appropriate. Okay, other questions or comments about the non-claims payment before we open it up to the template overall? It feels like what I've heard is option 1 or 2 with maybe some refining of the fields and regrouping to go for those larger buckets is the direction rather than the much more detailed granularity. I would ask you all, especially those of you who want to do some more internal consulting, to send us feedback on that. Like, what are the categories that would make sense if we were going for, say, three buckets? What would those 3 buckets be for you? That would be really helpful feedback to hear. Is that doable?
Yeah, that seems reasonable to me. Thank you.
Thanks. I think if any of the language in the current draft options makes sense, feel free to just point to that. But if not, don't feel constrained by that. Okay, let's open it up more broadly. Other questions, reactions, comments to the revised template or the guidance, knowing that there are a lot of holes still in the guidance that have not been filled in, and knowing that you just got this a couple days ago and have not memorized it in detail.
This is Jared from Cambia. I had a few questions, but are you looking for higher level questions or detailed ones or both? Or
Both.
Okay.
We're trying to work all of the kinks out of this, so let us know what questions you have.
So I was looking at the targets and the growth targets of 3.4% and trying to look at that in context of what I've seen in recent history. And I guess the overall question as I brought this back is, there's a lot of detailed questions about the claims, and then some interest in how it will all be rolled out and compared. And as I look at components of trend, there's obviously the unit cost piece of it. Then there's utilization that's somewhat addressed by risk adjustment, and just curious with that dynamic. So would love to hear a little bit about the roll up of the claims, what kind of comparisons are being made. And then the other piece on just hitting the target is, does the target reset every year, or is there any cumulative nature? Often what we see in practice is that lower years of trend are often followed by high years of trend. And so, if you look at trend uniquely year over year, you lose some of the long-term trend that we're all working to solve for. So a few questions there, but just a lot of interest in that level of comparative analysis that we might expect to see.
Yeah, definitely. Let me give some comments for both of your questions in reverse order, and then Megan, ask you for additional thoughts. I think in terms of the target, yes, it does reset every year, and that we are comparing year over year growth, and it will be compared to the 3.4% and then later the 3.1%. That said, we will also be looking at cumulative trend. We're starting to look at that now, going all the way back to 2013 and what trend has looked like in Oregon since then, and what are some of the impacts of that. So, and I think if we look at Massachusetts, they are reporting both. So every year they update, they look at that annual year over year change, and then they update their cumulative trend as well. But the comparison that then triggers all of the rest of the downstream conversations about what happened and accountability and all of that are the annual change. Megan, any reflections from other states?
So in the other states that are working on reporting, and I think the other states are intending to report, there's a lot of context that needs to go into these reports to describe what the trends are, and additional data analysis that that OHA and Oregon have the great benefit to have, to be able to dig into some data that's a little bit more detailed than what the cost growth target data can get at through this benchmark data analysis. And so I would just say that the context is important, and I think you're very right that it is useful to understand what's underlying the trends, and also to be able to describe the situations that you've experienced where a lower cost year might result in a higher cost year. So I think that's all part of the understanding that needs to be brought to bear in the actual public reporting of the information.
Thanks. And in terms of the roll-up part of your question, Jared, we do want to have those service category breakouts for the claims as part of the file, so that that's one way to look at the trend and some of the drivers, but it is not the only way. And that's where some of that additional analysis, in particular using APAC data, using or payers doing some of your own analysis, providers doing some analysis, to come and have those conversations about what those drivers are. The intent of the cost growth target data submission template is to collect the data for that high level overview with a little bit of information to see into the drivers, but it's not the only one. And there'll be a lot of that contextual analysis that Megan's talking about that get into more things about the unit cost, the utilization. And that's not something that we expect to build out comprehensively in this template itself. It would be the contextual supplemental analysis. And I don't think we talked about this last meeting, but one of the bodies of work for the program and the implementation committee and the technical group this year is continuing to build out the data use strategy. So what are those analyses? What other data will we be looking at? And I think a lot of the context will come from that rather than from this template.
Sarah, this is Vince Porter at Cambia, and I think this is relevant, but maybe it may not be. But one thing that we're certainly tracking is also just sort of like what legislative actions get brought in that could affect the cost growth. And looking backwards, even from 2018 to 2019, we know that there are taxes and other things that are being factored in. Has OHA, we certainly would like to provide that context, but I think it also would be useful for an objective body to provide that context. Is OHA thinking about how they're going to report on that information?
Yeah. So yes, we're definitely thinking about it. Whether it's how we're going to report on it, I don't think we're at the point of having a report yet to be that specific. But yes, I will say that our team is already tracking some of the policy changes that are happening now, so that we'll be prepared to provide that information when it comes time to report on this time period. I can say we're also digging into this as we look at the historic trend. So we've been looking at cost growth trend from 2013 to 2018 in Oregon. We're working on sort of a baseline report. And for example, one of the things we're really digging into right now is the impact of the Reproductive Health Equity Act and what that meant for spending in Oregon. So definitely on our radar. I think this will be a place where we'll want to get collective input. Like, here's all the things we're tracking. Did we miss anything? Were there any benefit changes? other mandates that we missed. Another example that's very much on our radar, although on the Medicaid side, is the new possibility to extend Medicaid coverage for 12 months postpartum. So that will be a major contextual piece for Medicaid costs. There are lots of things happening in both federal and state policy that we want to keep an eye on. I think how we'll report it and whether or not we'll be able to specifically say exactly this much of the growth is due to this is maybe debatable. Some of it might be really easy to identify, some of it might not be, but we do want to have all of that context.
Sarah, I'd echo a thank you for taking in that into the legislative context, where something the Prov Health Plan is acutely aware of, like all the other carriers. Behavioral health payment parity is something that's looming in this year that's likely to be a material cost add in the commercial space.
Yep. And I sorry, Drew, to cut you off, but I just want to remind everyone that in the accountability and in the way the measurement and the whole process rolls out, those contextual factors are taken into consideration. If we look at the commercial market and we say the impact of behavioral health pay parity is the primary driver and everyone's exceeded the benchmark because of that, that's okay. That's a reason that is a thing that happened, that was out of control, that was the sort of unjustifiable, or sorry, that was a justifiable reason, to use the old terminology, and no one would be penalized for that. So that is part of the process that's taken into account.
Thank you. I had to ask of where does what the market experience, the consumer, the people buying the policies, where does that even factor into this? Because I could appreciate the need for policy to understand how are providers getting paid more or less this year than last year or over time. But the consumer is insulated from that. I mean, to a degree. I know there's high deductible plans where there's a limit to that insulation, but ultimately, shouldn't we be talking about premium? And over time, you could look at small group premiums or individual premiums, or even Medicare Advantage premiums in Oregon, and conclude that, where the consumer has been insulated in Oregon. And I'd ask, so what about then what we're paying providers? We're finding ways to both properly compensate providers and produce an affordable product in the market.
Yeah, so I think this is another one of those contextual supplemental analyses that we'll bring into the program and wrap around. So it's not something that we're collecting, and it's not in the data submission template. It's not part of the official data that's calculated against the target, but it is part of that broader context. And this is a preview for the implementation committee meeting on Monday. We are going to start talking about what we're calling the framework for monitoring, which is the broader perspective of what's happening with quality. What are the impacts on the healthcare workforce? What are the impacts on the consumer? And that will include things like looking at premiums, looking at out-of-pocket spending. So that's all part of it. It's just not part of the template process, if that makes sense.
Yes, I mean, I understand it, and I'm glad to hear it's going to be part of the greater context.
And I would, to your comment about consumers being insulated, I think some of this will be a conversation for the implementation committee in the future and other policy tables, where we look at what are the cost drivers, what are things we can do, what are the right strategies. I would say that's a little bit down the road, and I don't want to get too ahead of myself on any of that, but I think the intent is that there will be spaces in the program for those conversations. Do other folks have comments, especially now that we're sort of talking at the policy and program level? Any other questions about how this all fits together?
I do have a question. This is Anna with United again. So with regard to the APM reporting that we currently submit to Oregon, I think that's based on a policy group CITES, correct? is there any plans to maybe incorporate some of that reporting into what you're asking us to do here? Because the states that we provide TME cost growth reporting, we don't do a separate APM reporting to those states. So it just seems a little bit redundant. We're pulling the same, data, but in a different criteria.
Yeah, and we've got Trang and Zachary on, and I'm going to ask them to give more specifics about the APAC payment arrangement file. But I think this is similar to what Gail was asking. We do collect some of this information, and we can look at it and use that APAC submission at the state level and at the market level. But when we start getting into the provider level detail that we need for the cost growth target program, we just don't have that in the APAC submission. And that's where we're looking for this additional detail to be added to the cost growth target. But Trang and Zachary, can you chime in?
Yeah, hi folks, this is Zachary. I can chime in, and then Trang, I welcome your thoughts too. Yeah, that's exactly right. The payment arrangement file through APAC, you're right, it is based on CITUS currently. It's been that way since the beginning in 2017. Because there are some kind of fields and some crosscuts of the data that will need that currently are not in payment arrangement file, we do need to kind of collect at least a piece of that into this data submission. I don't know if we'll get to it today, but the section after this non-claim section is about the standard deviation. So that, that's one example that there's nothing even remotely close to that in the payment arrangement file, yet we need that data element in this to understand the variance and the distribution of per capita costs for a given line of business or a given provider. So all that to say, yes, we fully recognize there does look to be some duplication here, but we're trying really hard to kind of have a different capture of the data because the use cases are totally different, and some require kind of additional pieces of data.
And just one more maybe editorial comment. I think when we look at how some of the other states are collecting this data, there's a timing issue of when they stood up their cost growth target program and when they stood up their all payer claims collection. And some states like Massachusetts, it happened much more in parallel. The data files were designed together. We're a little different. We've had our APAC file and data collection in place for a number of years, and this is the newer part. So we're looking to be as specific as we need for this use case without duplicating. But it means that in some ways it might look more inefficient than states that did it at the same time and had it really neatly organized.
Okay, thank you. And then another question I did have on timing. I think I saw in the draft DSG that you had a November due date, but then you don't have the DSG finalized. So
Yeah,
I'm just wondering, I'm
So,
sorry.
Let me talk about the timeline. Yeah.
The due date, I think I wrote November because that was what I was hoping that it would be. I think you actually have it sooner, and it would be around the same time frame that we are also being asked to provide other states similar data. So just wondering, especially Massachusetts, they did push back all of their due dates. We normally do our Massachusetts filing earlier, like in May. And now it seems like it's going to be this huge crash of due dates for us, and didn't know how flexible you are with your due dates, especially because your DSG is not finalized.
Yeah, great question, Anna. And I think there are some real considerations at play. So one quick difference about Massachusetts and some of their changes. Massachusetts was originally set up with their cost growth target program where they collected a preliminary data file and a final data file, right? And so there were two submissions and then they used both in sort of an iterative way. We previously decided with the implementation committee and some program decisions that we were only going to do one data submission. So in some ways that influences our timing. We want to make sure that we have a specific claims run out period before the data are pulled. We want to sort of find the right balance between mostly complete enough to work with, but maybe not 100% run out. And so that timeline will be similar for a lot of states because that's how claims work everywhere. I think in terms of what we're specifically thinking for our timeline, we want to collect the 2018, 19, and 20 baseline data this year. Because this is the first year we're collecting it, because we're still figuring it all out, because we're still developing the guidance, I would say there is some flexibility. What we're aiming for currently is September, and we'll talk about that more when we talk about the rules. Our assumption is that we will finalize the data submission guidance and the template this spring. So we're going to spend more time in April and probably May discussing it, and then it will be final. And then we're hoping that gives payers June, July, and August to work on the file. We might need more time. That might be terrible. We might need to revise that timeline as we get into it, but that is our proposed timeline. Once we get into the regular annual submission cycle, it might look a little different, and we'll figure out what the right date is before. But again, I do recognize that it is a crash of states as more states get into this program and create these requests, because the claims run out period on the cycle, and the desire for this is how can we have this data and report on it as soon as possible. And because it's claims based in some ways, there's already lag. And if we want to have a report out to understand what happened, and we cut those timelines as close as we can to the claims run out, the time to actually submit, the time to validate, the time to produce, that dictates a lot of the timing.
Yeah, thank you. I appreciate that. That does make sense. And just so you know, our data, we're not even able to run the data if your cutoff is June 30th until like mid-July. So I think you did kind of have that in one of the slides. And then I think in the slides it said like 8 to 10 weeks is typical for payers to, we actually need, that's if it's a single state, and we're currently working, between 6 to 7 states. And I understand that you want the data closest to, to the cutoff, but just something to consider if, we're working on multiple states with the same deadline. It's like you're asking the same team. There's only, so many hours of the day. So we would appreciate it if you could reconsider having a firm date there, especially if, the other states that have developed their programs are pretty much set. And I had mentioned Massachusetts because they did push their dates due to COVID restrictions. So all of their due dates now are also in fall, and we have about 4 to 5 reports we do just for that single state. So any flexibility you could afford us would be appreciated.
You're on mute, Sarah.
Classic, thank you. We'll talk as a team about the due dates, and I think in a few minutes on this agenda, we'll talk about the rules and the timing for that. But I do want to say that in the rules, we are planning on having an exception and a waiver and an extension process. So that will be something that anyone could apply for and say, hey, this year we're just not going to make the timeline. I will say there are some downsides of that, and we want to be careful of that. So I don't want to commit to, yes, everyone can have flexibility on the timeline if they need it for whatever reason. But and I hear your concerns, and especially as other states are getting into these programs, I think that these types of requests and the timelines, this problem will only continue. So thank you for flagging it.
Thank you, Sarah.
All right. Are there other questions, anything specific folks want to talk about in the template? Otherwise, I'll talk about next steps and we can move on to rules.
Yeah, this is Jared from Cambia. If we've got a few minutes, I had one question on the IBNR that was mentioned. It was mentioned that the factors would be applied for each of the categories, and then there would be an attestation required. We don't actually calculate IBNR as a company at the same level and split that the template requires. And so the attestation would be challenging or would require a significant amount of work just for this. And so just curious if there's ways to maybe simplify the IBNR requirement, maybe have an aggregate IBNR or report without IBNR. 6 months is probably sufficient that it'll be close to complete.
We are looking at a similar 6-month run out essentially for the non-claims payments, and looking at applying IBNR for anything after that. And I think at this point, there's a lot of flexibility in what that might look like or how that might be calculated. I think what we're looking for is just some understanding of how an organization does it. Megan, is there more detail here that you would add?
Yeah, so I would anticipate, so just to be clear, are you talking about claims or non-claims?
Claims. And part of my challenge is we do IBNR in aggregate, right, across all of our lines within Oregon, or each line separately. And so we don't do IBNR at the level you're asking for, especially with the attributed, non-attributed split. And so when there's a requirement to have an attestation that it's reasonable, like it's just not always reasonable to apply an aggregate factor across the splits. And so I don't know that we'd be able to attest.
Yeah, I think the intent is, so I would hope that with 180 days of run out that you actually would have very, very small percentage of IBNR. We've asked plans in other states, and in some cases it's less than 1% by the time 180 days passes. I don't know what your experience would be, but it's possible you wouldn't even have any IBNR.
Well, we always have a small amount, but my point is it's not, it would have to be calculated specifically for this report for us to attest that it's reasonable, and that's a significant effort. And I think we would rather just report without IBNR.
Yeah, well, so I don't think the attestation or that language is meant to be restrictive or is meant to be sort of legally binding. I think it's meant to say, are we all in agreement? Do we know how much, what percent of the dollars that you're submitting is estimated for whatever reason? I think maybe Sarah, maybe we could look at that language to make it a little clearer. I don't think it's meant to be an official.
Okay, because I think we would prefer some approach to not include IBNR, and then maybe in the supplemental exhibit have just what's our average IBNR after 180 days, if it's 1% or whatever, or just make a statement how complete we think the data is, as opposed to the exercise.
We actually had the similar discernment in Providence, and our actuary had the same that it's not feasible to calculate IBNR and IBNP at the distinction between attributable and non-attributable lives. We have one factor ultimately that we rely on. So
you couldn't proportionally spread it across.
We'd have to perform a study, because attributed lives tend to have claims. Unattributed, assigned lives are different than attributed lives. You're going to have different cost experiences between attributed lives and assigned lives, and you might actually have a greater. I'm actually not even sure which direction it would go, but it would seem plausible that you'd have a higher IBNR factor or lower completion factor amongst non-assigned lives.
Yeah, I think it would be worth understanding, though, Sarah, what is the experience at 180 days, so that you can use that information to make a decision here, because at least the experience in other states is it's really, really, really tiny.
So I think we need to talk about this a little more internally. I think where I'm leaning is that we might want to consider some threshold where if IBNR is within a certain percentage, or if it's only 1 or 2%, then it's fine. It can just be reported as that aggregate in like tab 6 as supplemental information, I think is what I'm hearing you suggest. I think if it's a lot more than that, or whatever the right threshold is, if it's more than that, I think we need to consider what that means and what the implications are, because the data will not be complete, and the trends and what we're reporting out for the year won't be complete. Does that, obviously more work to think about that, but does that concept of a threshold make sense to people?
Well, why don't you just let more run out?
Because then it'll be even longer before we can report. if we wait for everything to be complete, we'll be 2 years after the measurement year before there's a report. And there's already pushback about how long this program cycle takes in terms of being able to understand anything or take action in a meaningful way.
I mean, I think from a Cambia perspective, we'd almost rather just have no run out, and then, you know, each year is comparative in that it's everything paid by that time. Potentially there'd be an allowance if there was a significant claim paid after or significant recovery after the fact. There's maybe a follow-up way, but
And when you're saying no run out, do you literally mean no run out, like submit data in January, or do you mean like say 6 months run out?
6
and
months
then
of run out, no IBNR, sorry.
Yeah. Megan, did other states debate doing no IBNR?
No, but we have questioned a couple of plans about whether they have it or not to understand, and you mentioned most say they don't because they have like a 99.8% completion factor. So it hasn't become an issue, nor have any other plans brought it up as a challenge to report. So I will say that too.
Okay, I think I don't want to commit on anything yet. I think this is helpful. I think we want to talk more as an internal team. I think payers, if you have data that you could tell us, like tell us what % complete you are at 6 months out. I think that would be helpful for us to have just context across the board. Feel free to send that in. And then we can talk more about the level of granularity needed and how we might handle this.
Sarah, on a similar sort of completion perspective, when I look at the Word document on the premium portion, it says premiums as of March 31st for the fully insured market. But anyone in the ACA wouldn't have their risk transfer by that date. And so what is I'm just looking at that on the fully insured side, the run out allowed for the ACA seems insufficient. We don't get those risk transfer payments until July of the following year. So we don't know premiums technically until July of the following year in the ACA market.
Okay, I don't have a good answer for you off the top of my head, Jerry. I need to think about that some more, but thanks for flagging.
I had a similar note on the ACA risk adjustment. Some of the formulas that calculate, you know, the total medical expense or the net, or the NCPHI that I can never remember what it stands for, but they didn't seem to address the risk adjustment transfers.
Okay.
Question, those are the MLR payments, the refunds. Is that what you're talking about, Drew?
No,
the MLR is a different, that's a rebate. I'm talking about, and Jared and I are talking about the risk transfer within Oregon. In the ACA market, you're not underwriting, medical underwriting. So carriers who have high risk get receivable, and carriers with low risk tend to have a payable. That's not settled until July of the following year. And in fact, on top of that, there's a RAD-V impact, and there'd be that would carry over into multiple years out. But so consideration about how to manage the RAD-V impact in the ACA would be helpful also.
Great.
There's just really long tails in the ACA premium.
Yep.
Got it. Okay, I want to move us to rules, so we have a few minutes to talk about that, but this is all incredibly helpful feedback. And what I would request from you all is to take a look at the draft guidance document, the draft template, and send us all of these questions. April 7th would be our preferred date so that we can figure out additional edits and bring you revisions and questions for the April tag meeting. But please do send in anything that's on your mind, any of these concerns. This is all exactly the kind of feedback we're looking for.
So Sarah, I know you've asked us you want to move us forward, but we have a very significant concern also in pharmacy rebates. The tail on pharmacy rebates is wicked long also. And so please consider, I'm just begging you, please consider longer run out. I know you're balancing trying to get reports done. We're trying to balance giving you accurate information.
Okay. Drew, I might follow up with you for some more information on that for specific to pharmacy rebates, but thank you for flagging it. Okay, let's switch gears and talk about the draft rules. So last month we shared the outline for the rules. This month we're sharing the draft text, and we have some specific questions, and I'm going to hand it all over to Trang to walk through.
Yes, thank you, Sarah. So the draft rules, as it looks right now, is one of the documents that was sent out with this meeting. And in this, so you can look at that. But in these slides, we want to bring a couple questions to your attention and get feedback and comments. So the first one is about identifying mandatory reporters. So this DCBS enrollment Excel that we've mentioned before previously in this meeting, this is how we identify reporters for 889. It's also how we identify reporters for the APAC program too. And one of the questions we wanted to get your feedback on was aggregating or collecting the mean total lives across 4 quarters of data, or getting enrollment lives with a snapshot at the end of the year. Are there any feelings, preferences on that? The language we have in there right now is the same as what is done in APAC. So just to put something down there so people can look at it. Are there any thoughts, preferences? Maybe you don't have preference.
So for option A, are we aggregating for snapshots?
So sorry, let me back up 2 seconds, trying to add a little more context. I think so. Reminder that we have a criteria that was set by the implementation committee for which payers and TPAs and will submit data, and that's that they have 1,000 lives in Oregon. So then it becomes a question of, how do we know that you have 1,000 lives in Oregon? And where we are taking this approach of we the state will identify who we think those mandatory reporters are and then let them know. And that's similar to the APAC process where you get a notification. We've looked at the enrollment data from DCBS, from Medicaid, and we think that you meet the criteria. It's not something we're asking payers to sort of self-identify and opt themselves in. I think we're planning on, we will look and then tell you, hey, for 2020, for 2023, it looks like you're a mandatory reporter, heads up. We are also open to feedback if that approach is not a good one. But this question is then, what method do we use for identifying that 1,000 lives threshold? And APAC uses an aggregate of 4 quarters worth of data. When I've done some quick and dirty snapshots of finding out who I think the payers are for the cost growth target program, I've only looked at December of a year. And I think the question we have here, the real difference, and it's not difference between A and B. A and B are just texts that describe the same thing. Is there really a meaningful difference? Is it more accurate to aggregate across the 4 quarters, or is an end of the year December enrollment snapshot sufficient for identifying who should be reporting? Chris, I don't know if that really answered where you were going with that, but did that help?
I had misunderstood.
Sorry, thanks. I should have backed up. Yeah, there is a 1,000 lives threshold across all lines of business. So yes, the question is, should we aggregate across all 4 quarters of a year or not?
So, I mean, I'd offer unless there's a compelling reason to deviate from APAC, why not just stick with APAC's definition.
So there are some differences in who's included in this program versus who's a required data submitter for APAC. So I want to be clear that it's not the exact same list of data submitters. If Drew, you're saying why would we use a different methodology, that's totally valid. We can use the APAC methodology, but I just want to be clear that it is going to be a different list because the inclusion criteria are a little different.
Yes, the inclusion criteria is different and the threshold is different too. So in APAC, the lives threshold is 5,000. And for the cost growth target program, it's a lot lower because they want to.
Although I will say, looking at some preliminary data, it's really not that many more plans that would submit.
Oh, extra?
Yeah, I think it's only like, oh, I'm going to get this wrong. Don't quote me, but it really was not that many when we looked at the initial pass. And again, that was using just the end of the year, December 2020 enrollment snapshot. So I guess this is more of a question of how much does your enrollment really change and fluctuate over the course of a year? Is the December of the end of the year an accurate enrollment snapshot? Knowing that 1,000 lives is a pretty low threshold, all of you are above it. And we don't actually have that many plans that look like they're sort of right on that threshold where it might really make a difference. But if you're seeing really wide fluctuations in enrollment and you're a small payer, I think that's where we're concerned.
I think most carriers experience, this year might not be a good example, but in the individual market, most carriers experience loss throughout the year because there's just one open enrollment period, and then it tends to lose members as they become Medicaid eligible or gain jobs more often than people entering. It's about 11% difference between the beginning of the year and the end of the year. But it might not matter at all given the.
And is that 11% for the you said for the individual market?
Right. So if we had individual only carriers in Oregon, possibly, it could matter for some of those small ones, but I don't know if it really matters.
Okay, this is helpful. So what I heard was it probably doesn't matter. There is some loss in the individual market, but it probably doesn't apply to most of the payers. So it's kind of a non-issue. So why don't we just align with APAC methodology? Is that what I'm hearing?
Thanks.
I see a thumbs up. Any disagreement?
I don't see any. Okay. All right, so let's go to the next slide. Thank you. Aligning with APAC. The next item we wanted to talk about were test files. And right now this is from the compliance and enforcement section of the rules. But if we want to do this, we'll add it to the reporting section as well. Right now, we don't have test files written in rule. I believe we have a training webinar for new reporters to attend if you've been identified as a new reporter. But what are your thoughts on having test files be an official part of the process and then having it in rule? We do have, I will say, I believe it's right now it's set as a month from when the submissions are due to when we do validation checks. So within that month, oh,
sorry.
yes.
Trent, can you talk about how the test files work on the APAC side? Because that's where we got this idea.
Oh, yeah, sure. So on the APAC side, and I don't have the
exact timelines in front of me, but for APAC data submitters, if you are identified as a new reporter, it is part of the sort of onboarding process. I don't know if it's 30 or 60 days prior to the first submission of the year, all new reporters must submit test files to make sure their connection works, because they are submitting them to a data vendor, and to make sure their files are passing validation and intake checks like that.
And the reason we weren't sure if this made sense for the cost growth target program data submission is that the submission file is a lot less complicated than the APAC file. It's a lot smaller. It's not going through a vendor. It's not going into a portal. It's an Excel workbook that would be like almost certainly emailed to the state. And so we didn't know if it made sense to build this process in on the front end, and if you all had thoughts about that.
Well, my thought is, this is Jared from Cambia again, is this initial round is sort of a test anyway, right? So maybe just treat this first round as the test and not have separate test files if it sounds like it's going to be relatively iterative and maybe the same needs, right?
That's a great point. This initial submission is a test submission in many ways.
Yeah.
This is Anna from United. So just a comment on that. So I think what we're finding when we have to submit test files, like for Colorado, it's helpful when we don't know how they're validating the formulas. But in other states like Rhode Island and Mass, where in the templates, they actually have a validation process within the tabs, then there really isn't a need to do a test file.
Okay, I'm not hearing any strong argument for test files, so I think we should strip this from the draft rules and keep moving.
Omit. Yes. All right, thank you. And then the next slide, Michelle. Oops, one back. All right, the next slide is about what would a public use data set look like for data coming out of this program. Up there, you have a link to an example of what Massachusetts is publishing. And we have an example from APAC. So in APAC, very different program, but we do have a public use data set and a limited data set. And to request that data, there is a thorough application and review process. There are data use agreements you have to sign. But for this program, we wanted to start conversation on what would a public use file look like? What's the right level of data to disclose, and if we should consider certain types of access? So that could be maybe disclosing data only for certain purposes.
So maybe some additional context. I mean, I think in addition to the public-facing reports and the data that accompany that, the Massachusetts Data Book is essentially a clean and compiled version of all of their data submissions. It identifies the data at the payer and provider level, and it is available just online. You can click it and download it. No application, no request, no declaration of intent of how you're going to use that data. It is just available. While our APAC data it's very different data, has very different levels of detail and different protections on it. We don't have a data file you can just download and anyone can access it for any reason. There are some barriers there. And so I think what we're asking here is, given that this data is not, the data for the cost growth target submission is not the same level of detail as the claims files, it is aggregate data that you are providing. we want to make some data available, and we know that there's interest from stakeholders and others in having access to some of the data to work with directly. But we want to think about what that right level is. And on one end of the spectrum is Massachusetts, all data is available, you can just get it on the web, no problem. And on the other end of the spectrum is no data is on the web except what's in the public report, and you have to request it to get access to any of it. So I think, is there a preference between those two spectrums? What are your thoughts about maybe a happy medium? And I know we've got some stakeholders on the call who might be interested in using the data, so would love to hear your perspectives on this question as well.
Mm-hmm.
I think I have a question. I guess once again, why deviate from APAC rules? I mean, it seems like we already have sort of an established precedent. Why not just follow the same expectations APAC has set up with respect to access to our data? It's not impossible to get access, but there's rules and ways to go get the access. I would prefer we follow something like APAC. Ultimately, I prefer it just be used for the reporting purposes and no other, but I don't know if that's possible.
Sarah, is this something the implementation committee ought to discuss? As does it weave into the data use strategy? Because I know public use data, it was in the IC report as something they wanted. Yeah,
it's in the recommendations, and so I think there is a distinction that we can make, and maybe provide some more specific examples of what might be in each. I think there's the difference between taking all of the data files that you'll be providing and creating a master data file and making that available versus here's the data file that underlays the public report. And if you want the numbers that are in the public report, you can get them, as opposed to the file with the numbers used to create the public report. So I think we're definitely going to have the data that underlies the public report and make that available for sure. There'll be a way to access that, whether that's in an appendix or a supplemental file. But essentially the raw data is what we're talking about here. And I think, Drew, you're saying that should be accessible only through a process like we already have for APAC.
Yes, that is what I'm saying.
Got it. Do we have other thoughts, other questions about this?
No, this is
Sarah, I
John
just
from
want to
CVS
note,
Health, and I would agree with Andrew.
Sorry, who was that?
This is John from CVS Health.
Great, and you agree with Andrew?
Yeah, I think there should be a process in place.
Thank you.
Yeah, this is.
Note that, sorry, Richard, I just want to clarify something. It's not the raw data that Massachusetts is publishing, because there are some, with respect to pharmacy rebates, for example, that we understand is a sensitive data. And so it's not, it is an aggregated data set that does underlie their public report. It is not exactly what the payers report. And so I just wanted to clarify that, because I think that might raise some undue anxiety.
Thank you.
Yeah, this is Richard Gissom from Comagine Health. I think that there's great value in, as Megan just said, or as she described in Massachusetts, of not each submission from each payer. I don't think that we're arguing that the public should have access to that, but the summary data of those base data about all those numbers that go into figuring per capita cost growth, I think that is beneficial for that to be a transparent process. We're also trying to increase the literacy of companies and individuals in terms of healthcare at 20%, nearly 20% of our economy. It's important to improve their literacy and help them understand where their cost growth is spending is going. And there will be a lot of challenges in bringing down Oregon's cost growth from its current 6.2% or thereabouts to 3.4%. And I think transparency will build trust in the system. So I would argue in favor of following the Massachusetts model of having complete but not individual data file submissions, but complete summary data available on the web without going through a process for acquiring them. Thank you.
Hey, Sarah, this is Jared from Cambia. For me, I think it would be helpful to know what's being talked about. I mean, this is a pretty general statement about some data set or limited, but I think the details may be what matters, and
Okay.
would love a
Let
chance
me-
to see examples or what would be intended to be shared so we could provide some comments on it.
Yeah, definitely. I would encourage you to take a look at the link here on the slide and look at the actual Massachusetts data file, which, yes, Megan, as Megan said, it is not the raw submissions that each payer submits. It is a summary data file. It is very detailed, and it does include payer and provider level identified summary data. So I think take a look at that example, and maybe that'll help. And we probably should have previewed some of that content more, but I think take a look and let us know over email if your feelings change once you've looked at the Massachusetts data book.
And I'd like to just clarify something that I said, and I'm not sure if others would agree, but it's not, Providence isn't like stating that, hey, no one should have access to that same level data that Massachusetts is making available. What we're asking is that it go through a process to say, why are you using it? What's your intent? Like the APAC data process isn't just, hey, go see aggregate data. You have to indicate what your plans to use it are, and that becomes available so that we know who has used it and why they've used it. That's what I'm asking, is accountability for using the data, or at least traceability of using this data.
Okay, I was taking some notes on that. So again, please take a look at the Massachusetts data book and email any thoughts about this question as you've seen that. But Trang, you want to go to the last question?
Yeah, let's go to the last slide. Okay. So, and again, this is for this baseline year. And I know we know we're under a time crunch for this year, trying to get this data in and trying to get good data in. We've already sort of talked about the 180 days, the 6 months of claims rollout, and want to, I guess, open up for more conversation for folks to talk about this September timeline. I think in our original work plan, it was beginning of October. So, and again, it's the same timeline as it sounds like a lot of states, a lot of payers are submitting reports to multiple states.
So I think we heard in the earlier conversation a need to be clear about what flexibility is available for the data submission. We will incorporate that. If we asked you to pick today between a due date of September 1st and September 15th, is it fair to assume you'd all assume September 15th because that gives you 2 extra weeks?
Yes.
Makes sense. Given the timeline we were talking about earlier, where we hope to have the data submission template and guidance finalized this spring, May, early June, does a September 15th timeline for the initial submission seem feasible?
This is Yana from United again. I think we would like to meet internally with the teams that are involved in pulling that data, and then also depending on what your final DSG looks like and where we land with the templates. But I definitely want to just point out that 8 to 10 weeks to prepare data submission in other states, that's almost double for us, because especially this is a new state and a new program for us. We would have to pretty much start from scratch on the code. So just kind of, you know, give us some time to meet internally, and if we can get back to you on that. Thank you.
I would offer the same comment that because this is our first time submitting this, this seems aggressive. And I'm wary of our ability to meet even a September 15th with a 6-month run out window that doesn't give us a lot of time to put together the right code algorithms and populate the workbook, and then review the workbook for reasonability before we even send it to you. And there's a lot that goes into this. I think ongoing in future years, it does seem reasonable, but not for this year.
This is Dean Andretta. I concur with that. I think the timeline is really short here. And as a small plan, we have so many other competing resources that that turnaround time seems really dangerous from our perspective.
John, did I see you trying to jump in?
Yeah, so I would agree with everybody prior comments, which is, again, for the first time for the submission, it certainly is a short time period between the finalization of the guidance and the actual preparation and delivery of the files. And again, on a go-forward basis, depending on the types of changes that occur from year to year, that obviously has a big impact on what we have to do for coding, aggregation, and things like that.
Okay. I am not hearing anyone argue otherwise. I think those are all very fair points about the initial submission in particular. And I want to give a little bit more thought to the earlier comments about balancing the run out period and having more complete data with the time for submission and reporting. And I want to think about how that plays out, not just for the initial submission, but for future years on the reporting cycle. So again, I think if you have additional feedback on this, especially if you want to consult internally, please send us an email and let us know. And we will keep thinking about the implications for the timeline for the initial submission. I do think that assuming that there will be a September submission or, roughly ballpark September for future years is probably where we're going to land or close to, but let's keep talking about the initial submission. Okay, we're just about out of time. So I think if there are any other questions or comments about the rules, please again, email us those. We welcome all of your feedback. We talked about this a little bit in the first meeting, but our plan is to issue temporary rules in April, and those temporary rules will govern the initial data submission, and then we will have final rules that will govern the ongoing annual data submission that we'll finalize by the end of the year. So two-step process, opportunity to change again and review the rules more formally through a rules advisory committee process later this fall, but this will be for the initial data submission and to give us some general structure for the program. Are there any other comments, burning questions folks have for today?
Okay.
All right. Thank you again so much for your time and for all the feedback. We'll meet again in April, and we welcome all of your comments over email between now and then. Thanks, everyone.
Thanks.
Thank you.
Bye.
Thank you.
All right, thank you, Sarah.